This conference will now be recorded.
Okay, welcome everybody. My name is Peter Kafka. I'm speaking to you from La La Land over here in Maui, Hawaii, which is, I usually say, it's paradise until you get sick, and then you all live in paradise from my vantage point, because you've got doctors at your beck and call. So this is the advanced and recurrent call. There's a number of us that rotate doing the moderation of it. We've got close to 30. We might end up with quite a few more as we go along. Maybe Len, if you spot anybody new coming on or anybody else coming on, maybe you can kind of.
Yeah, Pat Martin just came on, I believe.
Yeah, right. Anyway, we'll try to, there's a number of people that have small things to talk about, but we have 3 new people and we're going to start off with them. What we usually do is we usually work with 3 or 4 new people each time, if there are that many, and give them a 10-minute priority to kind of talk about what their situation is, what their concerns are, where they're being treated, how old they are, when they were diagnosed, what their diagnosis is, et cetera, et cetera. I've got a few questions I'll run down with you. Some of you at least one of you I've talked to before, so we're going to start with him because I promised him. He was on last week and we didn't get to him. And that's Bob Smith, and he's another Hawaii compatriot. He lives on the Big Island of Hawaii, which is about 30 miles from me over the ocean. And like me, he's in a situation where it's kind of hard to get medical treatment. So I'm going to give him a chance to update us with what's going on with him. So Bob, how old are you?
Peter, can you turn your microphone down just a bit? We're getting some feedback from you. I believe it is you.
Is that any better?
Not really.
I see Bill Martello coming on. That's where the feedback's going.
Oh, what can I do to correct it?
Just if you're not speaking, please mute yourself. That would be the best bet. That goes for everyone on the call.
Okay, so Bob, how old are you?
I'll be 77 later this month. Entering late 70s.
Hawaii. And when were you were diagnosed? When?
Around August, September of 2018. PSA at that time was about 13. You want the?
Okay.
You want to do question and answer, or you want me to do it?
And you're a Kaiser patient, correct?
Correct. I'm a Kaiser Medicare Advantage patient.
Okay. Okay, so just to cut to the chase, you were diagnosed as a 4+3.
Correct.
And you've had a radical prostatectomy.
Radical prostatectomy in November of when was it? 18? November 18.
Okay.
And then PSA dropped.
Since then you've been put on Lupron.
Well, since then I had another fun surgery in April of 19, which was a robotic assisted lymphanectomy. I moved 15 lymph nodes from the pelvic area, and before that I had a PSMA PET, gallium 68 at UCLA. That lit up one iliac node, and then when they did the lymphanectomy, they found 2 others on the other side, interestingly enough, but all pelvic.
Okay.
PSA dropped down below 2, 1, 2s for a while. And then,
Right.
go ahead. Do you want to do a question and answer? Okay.
Okay, well, anyway, so I think you told me that recently your PSA has been rising.
Correct.
And rising at a rate where it's been actually doubling in a short period of time, correct?
Oh yeah. Well, after I had Lupron treatment, after 3 months, PSA dropped to 0.11. After 3 more months, it dropped to 0.07. And that was the nadir, 0.07 in November of 2020. And then in February, it started to go up. February 21 went to 0.55. March, it went to 1.95. And in April, 4.73. So you can see from 3 consecutive months, actually it's about 5 consecutive months, it went from 0.07 to 4.73.
Okay,
So very, very quick growth.
right.
Testosterone, it's interesting, Kaiser Hawaii reported my testosterone in April as 3.61. And in February, it was they reported 0.07. They reported in an unusual way, to my understanding. It was actually in April 3.61. So you have to take their value and multiply by 100. And I just found that out yesterday.
Okay.
I was wondering why my PSA was going up with with a fairly low testosterone.
Okay, well, I think that's a good topic of consideration. So, Bob lives, he's a Kaiser patient, but there is no Kaiser hospital per se on the Big Island. Is that correct? You're dependent on doctors coming over from Oahu?
That's correct. For routine care, primary care, I go to the Kona Clinic, and which is just a few miles away. And then any emergencies go to Kona Community Hospital, which is also just a few miles away.
Okay, so before we talk about this, I did give Bob the phone number for Angela Hartstark in Oakland. Suggested he contact her to see if he can even get her to be his oncologist, his medical oncologist, because otherwise he's got to be dependent on people coming over from Oahu once a month, and they keep changing and so forth. So it's not really a good situation here. But he's got a PSA that's doubling, even though it's low, it's still doubling in a fairly short period of time. And he's on Lupron, but he's not on any kind of second line anti-androgen.
Went up by a factor of at least 30.
Right. So does anybody have any thoughts on Bob's situation?
I might add that in Hawaii, Kaiser has no subspecialists in oncology. At least they don't have a prostate cancer subspecialist.
I have Andrea Harstock as my oncologist, and I have never seen her. I live in San Francisco. She lives across the bay. I have never seen her. I don't need to see her. I can get it all done with the tests she orders and with the results she sees. So you might have no problem getting her support in Hawaii or finding somebody there, somebody who else that she could recommend that's an oncologist that could help you.
And you're a Kaiser. I don't see you on the board. Are you a Kaiser Medicare patient or?
Yes, exactly.
Okay.
I'm Kaiser. I'm Advantage, just like you.
Okay.
And I've been
We're
working.
in the Northern California district, which is different than Hawaii, just for everybody.
Well, let me just say, Bob Smith, it's not really different. Unfortunately, Kaiser has very few specialty oncologists, medical oncologists. We have tried over the years, we spent many years advocating for genitourinary medical oncologist. Andrea was the first one. There's now 3 or 4 of them in Northern California. I still don't think there are any in Southern California. So don't feel that in Hawaii, or if you're in Atlanta or in DC, you'd be treated any differently. We've referred people to Andrea and to others for many years now. She's very good, and there's a couple of others that we could refer you to as well.
Okay, thank you for those comments. That is reassuring, and I was anticipating that if I did see her, I'd actually be telephoning or video chatting.
Yeah, I mean the other guy that we really like, I just lost his name for a second. He's Korean. He's fantastic.
Won Kim.
Won Kim. Thanks, Peter. Won Kim is just also great. They both came out of UCSF. They're both really, really smart docs. And I would say Won Kim, just as good as Andrea, really experienced, probably more experienced as a GU med onc. He practiced for longer at UCSF, but either one would be great. You can use my name. Both of them know me pretty well. But I think the biggest issue for you is we need intervention, and with some type of drug. When was the last time you were scanned?
And that would be the PSMA PET. And
Hey, Bob, could you speak up? Guys like me who don't hear too well, I can't hear what you're saying.
Yeah, you.
Okay. Yeah, that would be the PSMA PET scan that I had back in early 19.
Okay, so for sure right now, the first thing is you need another scan. What type of scan we can talk about, but with a PSA at 4.73, I would just tell your doc right now you want a scan, because it doesn't matter if it's even if it's a C11 or an F18, regular F18 with 4.73. Let's take a look and see and find out where this is coming from. Yeah. And the sensitivity is less important where you are. So the first thing I would say is get a scan. Then, because that's what Won Kim or Andrea Hartstark are going to need. Then we got to decide what are we going to do with that. And we have to take into consideration your age. That being said, I was a little late to the call because the last 2 days I've been dealing with one of my favorite men who's 85 years old and has just been through 7 rounds of chemotherapy. So, you know, age, if you're healthy, shouldn't deter you. And by the way, he got results from the chemotherapy. He's in a trial. So if you've got fairly widespread Mets, the standard protocol would be to do some chemotherapy. If you don't have, if it's just coming from 1 or 2 spots, then the consideration would be the right type of second-line anti-androgen for you, and possibly some spot radiation, but definitely a second-line anti-androgen. Having said that, I just saw something on MedPage today. I don't know if the other guys saw it, that a second study has come out saying they think that cabazitaxel is better than second-line hormone therapies if you are metastatic castrate resistant, which is what you are. So there's a lot of art in how to treat you. that we have good science, we know what works, but you need a really good experience. You need a urinary medical oncologist to help you decide which treatment is going to be best for you and which you can best tolerate. But what we do know is you shouldn't be hanging around when your PSA is moving like this.
I agree. Yeah, thanks for that. I had a couple questions for you. Is Kim Wan also in Oakland?
One Kim is on the peninsula.
Oh,
Yeah, he's I can't remember. He's somewhere.
he's Kaiser.
He's Kaiser. Yeah, he's Kaiser. He's not in Oakland. He's in one of the hospitals on the peninsula, but I can't remember. I forget which one.
Yeah, it's a small hospital. I looked it up and I couldn't figure out what it was. I can't remember the name of it.
Redwood, is it? Is he at Redwood?
I can't recall. Anyway,
he's one of the Kaisers on the I can't even. I'm drawing a blank of the county name on the peninsula, not Contra Costa. San. It's on the tip of my. Help me, Jeff Marchi. What's the county on the peninsula?
Santa Clara, San Jose. San Jose, is that what you're thinking?
Santa Clara. I think he's in Santa Clara County.
Okay. Anyway, he's you can find him on a Google search, but I wouldn't hesitate if you can get a hold of Andrea, whoever you can get a hold of. I wouldn't put it off. I'd start working on that. And I don't know whether they do Oxyman scans on Oahu or not. I believe they do, but I'm not positive. I know they don't do it here on Maui, and I doubt they have them on the Big Island. But
what kind of scan?
It's called Oxyman, AXUMIN.
Oh, okay.
And it's not as good. It's kind of like a PSMA, but it's not as good. But your numbers, it would be fine.
Okay. Why are you judging that I am castrate resistant?
Because you're on Lupron, your PSA is going up.
I was on Lupron for 6 months.
Oh, you're not on Lupron anymore.
I haven't been on Lupron since.
Oh my gosh, you're not on Lupron?
No, I was being treated with intermediate ADT, and so I was on Lupron vacation, which started in November of 20. And I see my oncologist, who, by the way, was also tomorrow, who was also trained at UCSF. So he might be, be pretty good.
What's your oncologist's name?
I can't remember his first name. Beal. This is the last name. Beale. Dr. Beal.
Yeah, I don't think he was I don't think he was in the genitourinary group. It could be, but his name isn't familiar to me. But okay, so I didn't realize you weren't on Lupron. I thought this was all happening whilst you were on. Okay, so the first thing is.
Sorry, I didn't make it clear.
David, Rick, hold on. I think he said his T levels were like 3.
3.
So,
No, he said 300.
That's the way, 361.
Oh, okay.
Yeah. On April 7th was my T level, which was reported by Kaiser Hawaii as 3.61.
Okay, so
I guess my question, Bob, is what was the decision to take you off of ADT? What motivated that?
The urologist who was taking care of me at that time, and I agreed to try it out. It's been tried many times before, I understand, and that there wasn't any evidence that it was better or worse than other plans for ADT treatment, at least Lupron. So, and its side effects were less. So,
But right now, are you getting any treatment at all?
no, not till tomorrow at the earliest when I see the oncologist.
And right, but your PSA is going up.
Right. So,
Correct.
so let me just say this. A couple of things. When was that testosterone taken?
April 7th.
Okay, so that's good enough for a baseline. That's close enough for government work. So what you really need ideally is a scan right now. An Axumin scan would be fine. If you could get an Axumin scan, ask for an Axumin scan. It's FDA. It is approved by the FDA. It should be available through the Kaiser system. But if not, you need some sort of a scan.
Okay, is that
And
the same as a bone scan?
it's different to a bone scan because it is PSA specific. It is prostate cancer specific. Okay? So that's why the Axumin is a little different. That's the first thing. Secondly, don't let them give you a Lupron or an LHRH shot if it's an agonist without a buffer. So they should know this, they should do it, but not all the doctors do it. But there are two types of LHRH drugs. There's an agonist and an antagonist. And if you're getting the agonist, you need to be on 10 or 15 days of bicalutamide first. Okay?
Okay, that's Casodex.
Casodex. So if he says go down and get a Lupron shot, you say no, sir. I need to be on a bicalutamide because we've seen it happen in Kaiser. Okay?
Are you worried about the flare?
Yes.
Yes.
Okay? So you have to be your own best advocate. And if they're going to give you an antagonist, which they don't usually do because it's a more expensive drug, you don't have to worry about it. But if they're going to give you an agonist, please be sure to take 10 to 15 days because we don't know where that cancer's coming from right now. And you need to get that Axumin scan quickly before your PSA is driven down, and your PSA could go down quickly. All of that said, what I said to begin with, which is the abiraterone or the chemotherapy is still relevant because that should now be given with the LHRH. We now know that if there is metastatic activity, which there is likely in your case, we don't just use an LHRH anymore, we use an LHRH with something else. So the LHRH is fine as long as we can get you scanned quickly so it doesn't drive your PSA down so we don't see what's there.
I see. Okay.
And that's why I think that you ask your oncologist, Dr. Beal, say, Dr. Beal, I'd like to get Dr. Kim involved or Dr. Hartstark involved because I need a specialty GU med-onc. I want one. And that's what they do. That's what they're there for.
Okay. So you think the second treatment, along with some kind of pill, an actual or shot, should be chemo?
Well, it depends on the extent. The second treatment could be a pill or it could be chemo. It depends on the extent of the metastasis.
So it could be enzalutamide or
Right.
something like that.
But Peter, I think we got to move on. I think
Okay. But Bob, keep in touch. I'll keep in touch with you. I'll check in and see how it goes tomorrow. Okay.
All right. Thank you, everybody.
Okay.
But Bob, let me one last word. You really need to be insistent. You know, that you need to be your own best advocate.
Okay. I hear
Yeah.
you.
Okay. Okay, let's, Bob Bordiga. Let's move on
No,
to you.
Yes.
Bob Bordiga's not new, Peter.
Okay, oh, sorry. Okay, Tom and Linda. Tom, you still with us here?
They're there. Yeah.
They're there, okay.
Yeah,
You
we're
got an
here.
idea? You got an idea what the drill is here? So,
Yes,
Tom, where do you guys live?
Springboro, Ohio.
Okay,
Just south of
And-
Dayton, southwest Ohio.
okay. And how old are you?
69.
Okay, and when were you diagnosed?
I was diagnosed officially December 2nd of 20.
Okay, so pretty recently. And what did they say the diagnosis? What drove you to diagnosis, and what kind of, did they do a biopsy, and what's the
Yeah,
scoop
well, I'll
here?
give you, about 3 years ago, I had a simple prostatectomy.
3 years ago.
About 3 years ago. So that's kind of key on what my treatment is going to be. So in September of 20, I went to my GP. I was passing some blood clots. And I also had some groin pain, but that turned out to be a broken inferior pubic bone, I guess it is. So my PSA at that time was 5.8. So I was referred to a urologist, and he did an exam. He was convinced right then that I had a serious problem. So we did a CAT scan, which showed in my lower lungs, because the CAT scan only does a portion of your chest, or it only goes up to the lower part of the lungs. So I had some nodules in my lower lung. So we did another CAT scan of the lung area. So I had a lot of nodules in my lungs.
Look,
So
Tom, I think we're all a little confused. When were you first diagnosed with prostate cancer?
The cancer itself with the biopsy.
the biopsy was, well, December 2nd was the official diagnosis.
But didn't you just say you had a radical prostatectomy in 2018?
No.
I had a simple prostatectomy. They
Okay.
didn't take,
Okay.
they only took out a portion.
When were you first diagnosed with prostate cancer?
December 2nd of 20.
Okay, so why did they do a prostatectomy in 2018?
I was having trouble urinating. I had and it was causing a diverticulite in my bladder. So at that time, I had robotic surgery to remove the diverticuli on my bladder, and at the same time, they did the simple prostatectomy.
So in
So
other words, back in
2018, January 2018.
Okay, so back in January of 2018, you had surgery on your bladder, and at the same time they removed your prostate.
No, it's just a portion of it. A simple prostatectomy, they removed the top portion of the inside of the prostate.
Okay, so you had a partial prostate. When you say simple, that doesn't really mean much. You had a partial prostatectomy.
Okay, yeah. Well, what they called it simple, that's what they called it here.
Okay. So it's unusual. I don't think we hear of this too often. So so after they did this simple prostatectomy, what was your PSA doing? Was it always very low?
Yes. I don't know the number back then.
Okay. And then when you, in December of 20, when they diagnosed you, when they diagnosed the metastatic disease, what was your PSA then?
In November, it was 6.3.
Okay.
In September, it was 5.8.
Okay, so as you speak today, you still have a good portion of your prostate left, correct?
Yes.
Yes. I guess so.
Okay.
My wife's correcting me.
Right. I mean, the reason that's important is because we have to take it into account when we look at any of these numbers.
Okay.
Now, they showed the metastasis, or the CT showed some spots in your lungs.
Yes.
Did they biopsy those spots?
Okay.
I'm given exact dates. Just
In I had a prostate biopsy done in November of 20.
4 plus 4.
Yeah, my Gleason was 4 plus 4, stage 4. And at that time, they also did a cystoscopy, which was negative.
Okay, how did they know you were stage 4 in November of 20? How would they know that in December of 20? Was there something seen? Because they can't tell that you're stage 4 just from biopsying your prostate.
They were basing that off of the CT scan of the lungs.
Okay, so did they biopsy the spots in the lung?
We tried. We did a bronchioscopy in November, which was inconclusive. They said it was a low chance of getting any good material to test.
Look, here's what concerns me. We'll talk in a minute about the doctor you're seeing, what type of doctor, etc. But if I've got a good portion of my prostate and they know that there is prostate cancer in that prostate, how many cores did they take in November of 20, Tom?
6.
And how many of those 6 had cancer?
All of them.
And were they from all around the prostate or just from a certain portion of the prostate?
the left half. The left half.
Left side.
The right
Okay.
side's benign.
Linda, you can speak up please speak up by all means. How are you, Linda?
I'm trying to coach him so he's the person who's talking, but
Don't worry, you don't have to do that.
okay.
Listen, Susan spoke up for Ron most of the time.
All right.
So you can speak up for him if you have the information, and I'm very glad you brought him into this call. Well done.
I do get some brain fog from this medicine.
Okay, so here's the thing. It's not clear. I mean, we're not docs, but we hear a lot of this. Clearly, you have cancer. Where have these additional spots been seen? In your lungs? Have they been seen in your bones anywhere?
No, we did a bone scan in November, and that was clear.
So, and what sort of doctor are you seeing right now?
Medical oncologist.
He's a medical oncologist.
Okay, but he's a local guy, right? In
Well,
Greensboro?
no, it's from the James at Ohio State.
Okay, and is he a genitourinary medical oncologist at the James?
Yes.
Okay, because we have other people that are at the James as well. Frank, who's your doctor at the James? Where's my man?
Yep, just had to get my mic on. Amir Mortazavi
Right. And
is
who is it?
my doc at the James, and he's a GU oncologist.
Right. And who is it that you're seeing at the James, Tom?
Dr. Parikh.
Parikh. It's
Okay.
Parakh.
Parakh.
Right.
Now, does that name ring a bell with you at all, Frank?
No, it does not.
Okay, I think you've got to check and see if this guy's a genitourinary medical oncologist. Because
He is.
he
Yeah.
is.
Yes.
He's a GU med onc. Okay.
Yeah.
So the concern that I have, if it were me, was whether in fact I have metastatic prostate cancer, because my PSA is 6.3. I've got a lot of my prostate left, so I can be making it. I don't show it anywhere else, and I can't confirm it in my lungs. But they're treating me. It sounds like you're getting hormone therapy. Are you getting hormone therapy?
Yeah, 2 weeks before my diagnosis, they put me on Casodex. And then on December 2nd, they put me on Lupron.
Okay. So I would be asking my doc, what makes you think I have metastatic prostate cancer?
Well,
Go ahead.
Well, after that, I went to a pulmonologist to try to find that out. So he did the bronchioscopy, which was inconclusive. And at a later date, we tried, well, actually went to interventional radiologist to do a needle-guided or CT-guided needle biopsy. But the Lupron had shrunk the nodules, and it was too risky for him to go through with the needle biopsy. So the thinking there is that the shrinking of the nodules indicates it's prostate cancer in the lungs.
That's a fair conclusion.
So my urologist, we went through a bunch of tests there, and then we went to Ohio State for a second opinion. And they confirmed what the urologist was saying. And then we switched to the oncologist there at Ohio State.
So wait a minute. So where this Ohio, right at the James? This is where you're seeing the guy.
Right.
At the James, right. I got it. All right. Well, I guess I stand corrected now that you say that the nodules shrank, because that would indicate that they responded to the LHRH.
Right.
But what has your PSA done since you started taking the LHRH?
He added a second drug when he got his second shot, which is Erlita.
Okay.
So the Erlita brought his PSA. We went back after a month and did blood tests, and his PSA is down to 0.07 right now.
Okay. So that all sounds okay. So I think we now have a much better understanding of what's going on, and I'll shut up and let the guys come in and talk to you. I think we've clarified the picture a bit.
Well, I have a question for Tom. It sounded like you said that they gave you bicalutamide before your diagnosis. Did I hear that right?
That's correct.
That is bizarre. I mean, why would you give somebody hormone therapy when you haven't even diagnosed them yet?
No, I think they probably did it, had the numbers, and were ready to give him Lupron. I don't know that you're talking about 2 weeks before you're diagnosed, what you call your diagnosis.
Right.
Yeah. So when you say diagnosis, the biopsy, you got the biopsy results 2 weeks after they started bicalutamide?
No. That was, the biopsy was before the Casodex was started.
Okay. So you were diagnosed before you got the bicalutamide?
Yeah, that's correct.
It sounds like we're putting a puzzle together here. So what is Tom, voice your concerns, your questions, where you are now. What are your concerns right now as it stands?
Well, that one, since they couldn't really get a biopsy of the lung nodule, does the shrinking of the nodules because of the Lupron is a good indication of cancer in the lungs?
Or could it have just been an infection that was resolving itself?
Mm-hmm. Well, we don't know that, and you can't. Your PSA is too low to get a PSMA scan, so I don't, and they can't biopsy it. So I don't know what the solution is on that. Yeah. If it is prostate cancer, just with the treatments you have, perhaps that'll keep it in check. I don't know what the answer is on that.
Tom, did you have a CT and or MRI of your pelvic region?
A CT.
You had a CT?
Correct.
Of your pelvis, and it didn't show any any lesions outside of the prostate?
No, everything looked fine. The lymph nodes weren't swollen. What else?
Yeah, the only place it showed up was his lungs. No bone, no lymph nodes. And evidently that's unusual, but it can happen.
Very unusual. And you only had lesions on one half of your prostate, not the other half, right?
Yes.
Correct.
I think by definition they call that, what is it, Rick, T2? It's not T4, that's for sure. They're just speculating that you have a metastasis in the lung. I know guys who've had spots show up in their lungs that wax and wane over years, and they're not prostate cancer.
How do you find out? Other than going into, having some surgery and taking out your lung.
I think there are ways that you can find out today. Here's one. Look, we're not doctors. We can't give you medical advice, but we can give you some ideas to discuss with your doctor.
Okay.
We now have scanning that is prostate cancer specific. Okay. Because prostate cancer expresses certain proteins and antigens that can be picked up on these scans. So but you have to have a certain level of PSA in your body for them to see it. And so one of the things that you could do right now, how long a shot, Lupron shot, did they give you? For what period of time?
3 months.
Okay. So, and they gave you that shot on what date?
March 1st.
Okay. So that March 1st shot is gonna wear off somewhere around June the 1st, right? No, March, April, May, yeah, around June the 1st. And then the PSA is gonna have to return, the testosterone is gonna have to return to your body. Do you know what your original testosterone level was?
Okay, the testosterone. Right now it's below 7.
What was it before you got your? What was it before you got your first Lupron shot?
I don't know if they took. I don't know if they tested for that. I don't.
Well, again, this is the guy. They don't. A lot of doctors don't do it. This is why it's so important to do it. And we always tell our guys, make sure you get a baseline testosterone. So we've got to wait for your testosterone to come back, for your PSA to rise, which it will do because you've got a prostate or a good part of a prostate, and then send you for an Axumin scan. And that Axumin scan will identify any place in your body where you have prostate tissue. If it's not in the prostate, it means it's cancer.
Is that the PET scan with a different tracer?
Yes. Yes, it's a type of PET scan, yes.
Yeah, we had a PET scan done, but apparently the tracer used was not the one that I think you're talking about.
Okay, so what type of PET scan did you have?
I don't remember. It wasn't the one that is prostate specific.
Right. Okay. It was 18F probably.
Right. So
yeah, that's a.
Right. So what we would do, and what I would ask my doctor to do, is take me off all the hormone therapy, because the hormone therapy is going to suppress your PSA no matter whether you have cancer or you don't have cancer. So get back to your normal state and then do a prostate specific scan and check at that point if it shows up anywhere outside the prostate. Would you agree, Len and Herb and Peter and anybody else on the call? Would you agree that as a plan?
Yeah, I would. I would agree with that.
I mean, I would, and I would also ask, what about radiation?
Well, but we don't want to radiate because we don't know, there may not be a problem. Right. Well, there is
a prostate.
I'm sorry, yeah. I stand corrected. For the 4+4 in the prostate, agreed.
Yes.
I'm sorry, yes. And what about radiation? Yeah.
Whoops, I'm sorry, was somebody else going to say something?
No, go ahead.
This is Peter. We're going to have to move on, but I would just weigh in here. I think you need to have a good sit down with your medical oncologist, and if he is indeed a specialist, and really get a feel for what his game plan is. What, where he's taking this. Is he just going to just keep suppressing your PSA and put you in a holding pattern, or is he interested in what's going on? Because in your lungs and so forth, I think you need to have a good consultation with him and explore the options and try to get an idea where his thinking is in this. Because yes, you need to be your own best advocate, but you need to get him on board too, and about what you think you should do.
I mean, I think the question, Peter, also for me would be, how do you intend to determine definitively what those lung nodules are? what is your intent, whether to identify if those are cancer or something else?
Makes sense.
Right.
And I have a question. When they did your biopsy or tried to do the biopsy of your lungs, and they didn't do the needle biopsy, was that at the James or was that at your local hospital?
The cancer center here at the local hospital.
I had my biopsy because my prostate cancer metastasized to my lungs. They found it through an Oxyman PET scan, and they did a needle biopsy at the James and were able to confirm it was prostate cancer. So again, I don't know if that makes a difference or not, but in your conversation with your oncologist, that may be something you want to ask.
Okay.
Could I ask one question before we move on? Was what in your lungs, were they nodules or were they actual tumors?
They were nodules because they were about 1 centimeter, and from what I understand, for it to be a mass or a tumor, they have to be over 3
Right.
or over.
Okay.
Right.
Okay.
They were about 1 or less.
Yeah. So there were a lot of them, but they were very small.
Okay.
Yes, mine were also small, but they were malignant.
Okay, but they were able to get a biopsy out of it.
Yes, they were able to identify 3 nodules, each 1 centimeter, 2 in one lung and 1 in the other lung.
Okay.
All right.
Thank you.
Hey, thanks.
Hey, Tom and Linda, if you could go to the chat window, that's the little bubble up on the top right, next to where put an email address in there so we can keep in touch with you and give you reminder notices. Okay?
Peter, we have it.
Oh, we have it? Okay.
No.
Yeah, because I gave it to him.
Okay, there's a couple of people that joined later that I don't think I was able to talk to. I think Kang just left again. Larry Fish, do you have anything tonight?
Oh,
Dennis Correa, do you have anything tonight?
If you have time, Peter.
Okay.
actually, add me on now, Peter, if you have time.
Hi, Peter. Peter, thanks. It's Larry. I was muted on the phone. No, I'm fine, thank you. I just logged in. That's all. I'm fine.
Okay.
Nothing tonight.
Okay. Is there anybody else I missed earlier on in terms of asking if you had anything?
Stan Friedman, do you have anything tonight?
Yeah, Stan.
No, I have nothing. Thank you.
Okay. Rich, is it all quiet on the Eastern Front?
All quiet on the Eastern Front.
Okay. Okay.
Kang, how about you? Kang, do you have anything tonight?
I'm good, thanks, Peter. I'm okay.
Okay. Okay, let's go on. Let's go ahead now. Dennis McGuire, you're up.
Peter, did you ask Bill Martello?
I thought I did.
You
I
may
think
have
he
been-
dropped us.
No, he's still there at the bottom. Okay, I think
Oh,
you've
is he,
got.
Bill?
Yeah, Bill Martello said he had something.
Okay.
Yeah, do we have time for
You
me
want to go
to
with Bill
discuss my...
Martello? Go ahead. Go ahead, Bill.
Yep. Okay. We have time for me to discuss my situation, about 15 minutes worth. Okay. I'm 80 years old, and fortunately, I live in the Chicago suburbs. I'm close to terrific medical care. Well, anyway, and back in 2010, what's that? About 11 years ago, I was diagnosed with prostate cancer through a biopsy. My Gleason score was 4+3. And then for maybe 3 or 4 years, I traveled to Ventura, California from Chicago every 6 months for Dr. Duke Bond. You know Duke Bond, right? To do a color Doppler. Yeah. Anyway, I went to him, and then it reached a point where he said, "Oh, I'm sorry. Go ahead."
No, we're getting feedback from Rusty. So.
Oh, okay.
I got him. I knocked him out.
Okay. Sorry, Rusty.
Well, anyway, so it reached a point where Dr. Bond, after 4 visits, maybe 5, said, "Look, you better get some attention on this." So I went to University of Chicago, and I had a robotic prostatectomy in 2015. And let's see, and then I had my PSA was creeping up, so they gave me 39 days of radiation, actually at a local suburban hospital here, because the cancer had escaped the prostate capsule. And then my PSA went up a couple years later through a CAT scan, an Oxyman PET scan. I guess it showed a couple of spots on my left iliac bone, which is the tip of my pelvis. And I was told that the cancer had metastasized throughout my body. So I had 5 rounds of radiation at the University of Chicago and went on Lupron for 18 months. Then after that, my PSA stayed negligible. But 6 months ago, it started to creep up a tiny bit. And I had been under the care of a radiation oncologist at University of Chicago. But since my PSA continued to rise, my good friend John Ivory suggested I look up I guess it's called a GU oncologist, a genital oncologist, and at Northwestern Hospital. And she said, you're okay where you are now, but if it starts to creep up to, a couple of points, well, in my opinion, I should switch to a general oncologist. Anyway, that's where I am now. It crept up a tiny bit, but negligible.
Bill, I'll just jump in. He saw Alicia Morgan's. They know Alicia Morgan's, Bill.
Oh, okay, John. Thank you. Anyway, so I went to her, and she said, let things start to really move considerably, I should stick with my radiation oncologist. But personally, my wife and I talked, and we decided I would switch to Dr. Morgan.
Okay.
When things start to creep up. Right now, I'm still with the radiation oncologist. Anyway, so I'm not really looking for advice unless there's something you see in my summary that tips you off to something.
What's your PSA? You said it was creeping up. What is your PSA level?
Well, it was negligible, and I can't for the life of me remember the term. They said it's virtually negligible, but it did move a tiny bit. I don't have my file in front of me, but that's what they said. It barely moved up. So then at one point, though, Dr. Morgan said she thought I should get my PSA checked every 3 months, but my radiation oncologist said every 6 months is fine at my stage. But I don't remember the terminology they used, but it crept up a tiny bit off the needle from negligible.
And have you ever?
I'm sorry. From undetectable.
Right. Have you ever been on hormone therapy?
Yes, sir, for 18 months.
That was when was that? When you got the that was when you got the IMRT?
Well, let's see. I'll tell you. I was on that until a year ago. So let's see. That was it ended in mid 2020. So I started, I guess, in 2019. Sorry, I don't have all my records in front of me.
Okay,
I didn't know it worked
don't worry.
Way. Yeah.
Did you get the hormone therapy at the same time? Did they start it when they gave you the radiation?
Let's see. I think right after the radiation, they gave me the hormone therapy.
Okay. And what was your Gleason score?
4+3.
4+3. Okay. And that 4+3 was what was the Gleason after the surgery, or that was when you were biopsied?
That was when I was biopsied.
Okay. What was the Gleason score after the surgery?
I don't recall. I'd have to look that up.
Okay, so that's the important one. The one after the surgery is the important one, and that you were on 18 months of hormone therapy makes me think it was maybe 4+4. And it sounds all fairly normal. And I mean, the one thing I can tell you, which I'm sure John has said to you, is that Dr. Morgan's is a fantastic doc. She's very compassionate and she's very smart. And if she's saying to you that you don't have to do much right now, I would do that. The only thing I would disagree, not with Dr. Morgan's, but with your radiation oncologist, is get checked every 3 months.
Thank you.
I mean, there's no reason not to get checked every 3 months. It's cheap. It can be done, and there's no harm from more information rather than less information.
I agree.
Yeah, I would agree with that too, particularly if you've got a very small creep in your PSA. 3 months is smart to keep track of it, and just keep a log going of what it is.
Certainly. Thank you.
Anybody else have any comments or suggestions for?
I'm sorry. Before we leave me, could I ask you something?
Go ahead.
I ended up with from robotic prostatectomy with I guess I would call it severe incontinence, where I go through like about maybe 6 to 8 pads a day, and pretty heavily. And I was told that an AUS, artificial urinary sphincter, was the way to go. University of Chicago, Dr. Bales told me. But a friend of mine had that done.
Okay, let me interrupt.
Oh, sorry, go ahead. Yep.
We can definitely help you. We've got people on this call tonight who have AUS, but we cannot do it now because we've got to get on to the other guys. So what I would encourage you to do we have your email address?
Yeah, when I registered.
Okay. So if we have your email address, we'll put you on so that we get a reminder, and come back next week, next Monday night. And Jimmy, if you can, you're usually on. If you can be on next Monday night, and we'll spend some time on talking to you about AUSs and the whole incontinence problem. But we just don't have the time to get into it, but we can be a lot of help to you on that issue.
That's wonderful. Thank you.
Okay, good talking to you, Bill. I'm glad you joined in.
Likewise. Thank you very much.
Thanks for making the connection, John.
Okay, Bill, I don't see your email address. Did you register on our website?
Yes, I did when I registered, but what I could do is just send it to you. There's an email address on your webpage, right?
If you're already in the database, we don't need it. I'll check there too, but for good order's sake, why don't you send it to Peter or to me, or put it in the chat window, just for good order's sake.
Yeah, that's either rd@ancan.org or Peter K@ancan.org.
Perfect. Thank you very much.
Thank you.
Okay, Dennis McGuire, you're up.
Great, thanks, Peter. I have my second treatment of lutetium on Friday. So my first treatment was 6 weeks ago. Really no symptoms to report. So I'm ready to go for Friday.
Have you had a PSA yet, Mr. McGuire?
No, I have not. I just looked at my calendar. My PSA and scans are going to take place at the end of May. So that's the toughest part of this, is to, have to wait that long to see if there are results.
Well, you could always sneak out and get a PSA somewhere, somewhere else.
Yeah, I could.
Oh boy. Well, I mean, it's great that and basically you're not feeling any side effects at all.
No, it was really the first week where I had fatigue and low energy, but I think as the lutetium wears off, you bounce back.
Okay. We like that. Are you exercising?
Yes.
Good man. Just checking. I'm just checking.
Yep, every day, try to do something.
Okay.
Good deal. That's a good report.
And anybody else want to ask Dennis about his experience with the lutetium 177? Mr. Finn.
Can he remind us where is he being treated and how many courses of lutetium treatments are you expected to have?
Yeah, so I'm being treated at University of Wisconsin, the Carbone Cancer Center, and I'm scheduled for 3 treatments.
Yay.
Dennis, you said Friday will be your second treatment?
Second, yep.
Okay. Good luck.
Yeah.
Thanks, Len.
So we should probably check in with Mr. Finn at this point in time, because where are you with your lutetium treatments?
Well, I don't think I'm on lutetium, but just
oh yeah, that's
just
right.
an update on my clinical trial, and then I had just seeking some comments on something from the group. I had my first about 6 weeks ago. Had my first treatment. It's a proprietary molecule accompanied by radioactive iodine. In general, I seem to tolerate it fairly well. Had a little bit of fatigue. Interestingly enough, about 2 weeks after having it, I had like a day and a half where I felt really crappy, which is interesting because when I had Toxoteer, 6 years ago, 5 years ago, the same thing happened. So must be something unique to my body, how it tolerates these drugs. So I have my next treatment May 4th, and then we'll kind of go from there. My PSA is holding steady. It's not going up, so that's always good. Hasn't gone down dramatically, but the real progression of disease factors that we'll be looking at is exactly how my tumors are going. So that's kind of my where the clinical trial is. Any questions on that? And I had another quick question for the group. Okay, being none. Now the interesting thing.
Hold on. I'm just assimilating and making my notes. So the PSA is holding steady.
Yeah.
Which means 5.5. Is that around right?
I think it had gotten up to about 6.3, and I think now is at 6. But quite frankly, changes that's small changes. That doesn't really, to me, that's just holding steady. So we'll see. My next PSA will be week from Thursday, so we'll see if it goes down.
And what did you say? You said you responded badly 5 years ago. Was that to some sort of iodine drug as well?
No, it wasn't. It was docetaxel, but I had the same thing where you had the same sort of humbling things of losing your hair and fingernails and stuff. But what really hit me was like 2 weeks out, I had like 36 hours where I really kind of felt like crap. And it wasn't quite as severe, but I had the same thing with this drug. So don't know if that has any correlation or not, but it was kind of an interesting fact of the day. So
it didn't have anything to do with a COVID vaccine, did it?
Nope. I'd already been vaccinated. Well vaccinated. Okay,
So-
you're gonna keep up here, Rick?
The drug
Yeah.
the drug you're taking it's not a chemo, but it is kind of like poisoning you. Is that correct?
No, it's a PSMA.
PSMA directed.
it's a
Oh,
It has
PSMA
iodine.
affinity drug. It's part of the Arrow. Is it the Arrow study? Herb, I forget.
Right.
It's a national survey and or national clinical trials, but it's a PSMA affinity delivery of. In this case, they're using radioactive iodine to try to kill the cancer cell.
okay. So
Okay.
so it is an attack type of drug.
Yeah.
Okay.
And they'll be doing some dosimetry and some other things later on just to determine in general how well, this drug is actually, dispersing within my body, whether it is going to my tumors and so on. That will be after my second dose. I think I get the dose, and then soon thereafter I get a bunch of scans, and they can determine, is the drug going to where they want it to go.
Right.
So how many doses?
I'm not a chemist or anything, but it doesn't surprise me that when you take drugs like this or docetaxel, that you get some pretty heavy duty reaction because they are attacking. Yeah.
Well, yeah, I'm actually pleased because it's for 1 day and a half. Although I've had some days where I'm a little bit more fatigued, I really have felt pretty good. So,
Good.
I have one question.
something
Have you noticed any changes to your blood counts, your reds or your platelets?
My lymphocytes are down. My lymphocytes are down, and they're at or just below the appropriate range. And so that's something we'll be following up on. But right now, that's the only one that I've seen in my, I'm getting blood draws every 2 weeks. That's the only one I've seen seems to have changed much.
How many doses are you getting in total, and how far apart?
I'll get four doses. They're about approximately 8 weeks apart. So I'll be doing this through, I think my last dosage is, it's either August or early September.
Okay, great, thanks. So you have a question?
Yeah, the question I had for the group, it's interesting. I've had I'll just say soreness and at times swelling in my jaw that I've had actually since November. And so, so in November, once I felt it and I felt like, oh gosh, I might have to have a root canal or something on it because it was very sensitive. I went ahead and stopped taking Xgeva at that point. And so I haven't had any Xgeva since November. And so, I went through my endodontist, we went through my oral surgeon who did some implants for me back in 2009. So we went through all these different avenues, and the dentists basically were stumped. So I went to ENT, we did some assessments. We looked at the I had a PET scan in January, and then as part of the study, I had another PSMA, and then that was an Axiom PET scan, and then I had another PSMA PET scan in at the beginning of the study, so it was like late February, I believe. Each of those showed activity in the jaw, but none of them seemed to indicate that was prostate cancer specific.
So Mark, what your salivary glands are full of PSMA.
Yes.
The fact that it picked up PSMA around that area is totally normal.
And so what we did is we then did an upper jaw, did an upper head jaw MRI, and you can see from the MRI that on my right jaw there's something going on, and really it comes down to the ENT is saying, well, it's probably another prostate cancer lesion because this guy has metastatic disease. My oncologist is tending to say, you don't see it in the jaw very often. At least I have two oncologists. One of them says they have seen it before, and the other one says, really haven't seen that. That would be very unique.
Are you taking denosumab?
No, I don't believe so, because I don't know what the hell that is.
No, he just said he stopped.
Denosumab. Xgeva. I stopped Xgeva in November when this first started to get this pain. I stopped
okay.
the Xgeva.
Got it.
And so any dental, I've had like, you know, I had some dental work since then that was like just tooth work, but anything that gets close to the bone, I haven't had anything since for a long time. So anyway, and in fact, the only time I had one dental implant during the time I've been diagnosed, but that dental implant was was on my upper left jaw, and this was on my lower right, and we got me off of Xgeva for probably 8 months at that time. Well, in fact, I was probably off Xgeva for closer to 1.5 years because my oral surgeon is very, very compulsive about how he goes about it. So the current plan is we're going to do a biopsy of the area to determine if it's prostate cancer, some other cancer, which my ENT thinks is pretty unlikely, whether it's some sort of cyst or some other thing that they can't really identify, or what probably, bothers me the most is if it turns out to be some sort of mandibular necrosis, which, usually that happens when you're messing with a bone and you're on Xgeva. This would be a case where it happened even though the times I messed with a bone, I was off Xgeva for periods of time before any treatment and well after any treatment. So I didn't know if anybody had any additional questions or thoughts on that.
Well, I don't know, maybe somebody else can comment, but is this a case for an Axumin scan?
Well, I did an Axumin scan in January, and the Axumin scan showed that there was activity there, but it was not, did not seem to be prostate cancer. And then the scan that I got, which is the PSMA specific, or PSMA PET scan, which I got in February, it kind of reinforced what the Axumin scan was, that was not prostate cancer. So based upon the two PET scans, two different technologies, you'd say that it's not prostate cancer, but who knows?
So you are going to have a biopsy of it?
Yeah, that's my plan, unless you guys think I'm going to die from it.
No.
God forbid.
I mean, it's a pretty uncomfortable biopsy, and so that's unfortunate. But I'm a big boy. A lot of you guys have gone through a lot more. So,
what was your total time on Xgeva, Mark?
Len, why do you always ask the tough questions? I think I went on Xgeva. Yeah, I think I went on my first Xgeva, Len, probably right around the time I had my docetaxel or soon thereafter, and I had it for a long period of time. I think even I had like a 6-month vacation from ADT, and I think I still kept doing my Xgeva. Then when we determined I had to have an implant, my upper left, we stopped the Xgeva for 2 months. I was off for 14 months, and I was back on into. So I guess probably since January of 2016, I probably have been off it for 14, and then additionally for the last 6 months I've been off 20 months. So let's just say 2 years. So since 2016, my math's right. I guess I've been on it 3 of the 5 years.
So you did have an implant after you had begun Xgeva, even though you stopped it before the implant.
Yeah, I stopped it like 3 months ahead of time, and then we went through the implant process with this particular oral surgeon. Is about a 12-month process, and then I waited another 3 months or 4 months before I started back on it. But again, not to say it couldn't be anywhere, but that was an upper left implant. The problem I have is lower right.
Okay, well, let us know what happens with the biopsy.
Okay.
Looks like Don Price dropped off. Jake, why don't you update us? What's going on?
Okay, thank you. For those of you who don't know, I had 23 sessions, weekly sessions of docetaxel. I ended them in January because my PSA went up to 162. It got down to 80 for a couple of months, then went up to 162. So then since then, I've not had any treatment other than my Lupron shot and as a meta. I had my PSA taken the other day, and my cancer is marching merrily along. It's now, PSA is now 373 from 162 in January. And my alk phos went from 61 in January to 160 something. So it's practically tripled in 2 months. I consulted, based on some input from some of the guys on the call, I had a consult with Antanarakis from Johns Hopkins, hoping that I could get a compassionate use for a new drug called Veru 111, VERU 111. And they turned me down. So he suggests now that I either get Xofigo or a new old chemotherapy drug. And I'll put it in a box because I can't remember how to pronounce it.
Cyclophosphamide.
Show off, Herb. Go ahead. Yeah, so I'm waiting to hear from my oncologist. I prefer that to Xofigo. And it sounds like there has been some, based on limited research, apparently cyclophosphamide has been somewhat successful in treating prostate cancer, advanced prostate cancer, after docetaxel, after a lot of other treatments. So that's what I think I'm going to go for, and I'm going to kind of insist with my doctor that we do that. That's my update.
We're pulling for you. I mean,
Thank you.
Yeah.
Sure.
I know you are, and I appreciate that. That means a lot.
We've seen a couple of studies recently on this cyclophosphamide. Dr. A recommended it, and then soon after that, I saw another. I read something else about cyclophosphamide. Cyclophosphamide could be a good option. Don't know very much about it. Maybe Herb knows a little bit more about its process. Nor do I know much about side effects. But you know, obviously we hope that you'll respond to it. I mean, I remember the last thing I saw was something about somebody who was not responding to anything else with metastatic, then responding to the cyclophosphamide. Len or Herb, have you done any research on the cyclophosphamide?
Well, I think I sent an article to Jake and Herb and possibly you too, Rick, showing that cyclophosphamide certainly did have activity in prostate cancer in metastatic CRP.
Right. So cyclophosphamide works through a different mechanism than the other drugs we're used to. It's an alkylating agent, so it puts extra molecules on your DNA so the DNA doesn't replicate so much. So that's the basis of its cytotoxicity. So it's different than Taxol, which is directed against microtubules. So it's got, and I was the one that I did the literature search, and yes, a single patient doesn't mean anything except if it's you, and it's great that there was this remarkable response to cyclophosphamide in a patient that who had basically didn't respond to anything else. So to me, it's worth a try.
Yeah, I agree, Herb. I looked it up too.
It's oral. You don't have to go get infusions.
Right. apparently the side effect profile is pretty good. There's no cardiac toxicity that they mentioned. There's no peripheral neuropathy, which is a big issue. That's one of the reasons my doctor stopped me on the docetaxel, because I was having peripheral neuropathy, and that's why she doesn't want to do cabazitaxel. But there's been more studies than just the one that you showed me, Herb, with more than one person, and they've kind of calculated that the PSA reduction of 50% or greater was occurred in about 25% of the people who took it. Again, a small sample, but it was only like a 40-man trial. But apparently, this is a very old drug.
Yes.
It's also you can get it by infusion, I believe. But the oral part of it, and they call it metronomic, where they do the pill. My brain just froze. Forgive me.
When would you start it? When would you start it, Jake?
Well, as soon as my doctor orders it. You know, she'll be in tomorrow. I'm hoping I'll hear from them tomorrow. I'm sure it's a specialty drug. I'm sure they'll have to go through the specialty pharmacy, but I'm hoping within a week. If she approves it. If not, then she needs to come up with something else.
No, they'll approve it.
I think so too.
It's an old drug and it's likely to be cheap.
Yeah.
Did you send her the studies, Jake?
No, I did not. I figured she can do her own research. It's just not that many. There's not that many. She doesn't. Her email is funky. I had to send it to her clerk, who then prints it out. So no, I did not send it to her. But if I need to, I will.
Okay. Well, we're in your court here. We're thinking about you.
Thanks, Peter. Appreciate it.
Jimmy Greenfield.
Good evening, one and all.
You got to speak up.
I will speak up. I will speak up now. Is that better?
That's better.
All right. Glad to see everyone. Thinking about you, Jake. I'll be thinking about you, man. I have nothing but good news, so I'll make it brief. And I had my artificial urinary sphincter activated yesterday. And I found it to be, I've been in pretty much in a state of euphoria since I left the office. It's easy to use. I'm dry as a bone. And after being heavily incontinent for 19 months, I don't have to explain to you how good it feels to be walking around without that anymore. And I'm especially happy that, fellas, you really don't want to reach down there and start squeezing your scrotum, but once you find the button, you lose your hesitancy, and you just got to make sure it's pointing the right direction when you hit the button. So there's a little dexterity involved.
So it's not Bluetooth?
It's not Bluetooth yet. I'm sure that's on the way. I'll be on it as soon as it's there. But the greatest thing about it, it closes itself off. So you do not have to deactivate it. Now, probably you may know this, but if you should ever have a occasion to use it, it's so easy to use because you activate it, but then it turns itself off. It closes in about 2 minutes. And actually, I found that, when I'm finished, and it didn't keep going. I didn't have to wait 2 minutes like I thought I'd have to. I just stop when I stop, go back. So it's just a dream come true. And the difficulty I had in the surgery and all that has been more than worth it. And I'm glad I decided to get it, and just pretty doggone happy, fellas.
Great. We're really glad.
Thank you. So if anybody ever wants to know about it, want to ask me questions, of course, I know it's not terribly common, but incontinence after prostatectomy is supposedly 5% after a year. Well, then I got the lucky, booby prize, and I can't be the only one that's ever been on this call that might still have problems. So anyway, I'm just here if anybody wants to know anything about it or anything.
So Bill Martello, I'm assuming you're listening carefully to this.
Who?
I certainly am. And I'm going to wait until next week or the week after to ask further questions, correct?
Or we can put you in touch with Jimmy.
Yeah, well, that's a great idea. But actually, Well, on second thought, let's wait until there's other fellas on there with the AUS, because a friend of mine had it and it didn't work out well, and he had to go back again. So I'd like to know from people. I mean, this fellow's ecstatic, and I understand it. At the same time, you know, my friend had it for 3 months and went haywire. So I'll save it till a future meeting.
Okay, we built two things. One, right now we don't know anybody else with an AUS, although we've had guys before and they've had.
Okay.
We haven't known anybody who's had issues with them, but I'm sure there are. The other people that we know, it's worked.
Yeah.
Secondly, you're joining by phone, so we don't have your email information. So right now, I think we're unable to connect you with Jimmy, although we're happy to do that. I suggest that you email me or Peter. My email is rd@ancan.org, and we'll put you in touch with Jimmy.
Thank you. I'll do it right away. Thank you very much.
And we'll connect you to Jimmy, and you can go from there.
Thanks, Rick.
I might only add that, like with a lot of, we always talk about finding the best doctors, finding the best surgeons you can. I worked at this for a little bit, and this is not a surgery that is as commonly done, of course, as a prostatectomy. It's not as commonly done as a lot of things. And I would gather that it takes a certain amount of experience and dedication and skill to do this well. And just like anything else, it may not always be done as well as it should be. I'm not going to speculate that, but that's kind of, pretty much the truth about all surgery. So I'm always happy to share my happy story, but hey, this is just yesterday. Mine could go haywire in a few months too, and if it does, I'll be talking about that too. But for now,
Sounds good.
It's all good.
This is Alan. Just a quick question to Jimmy. How bad was your incontinence before the surgery?
It's about as bad as you can get. It got worse after the surgery between then and when they activated, but that's understandable because they just put the device in there. But for the 18 months leading up to the surgery, I never got any better than many, many towels. I didn't even use pads. I used towels. And sometimes the towel would soak through, and if I didn't tend to it right away, the pad underneath it would be soaked through as well. Usually I changed the pads over and over again because it was easier than, the towels, because it's easier than changing the pads. So the short answer is it was real bad. It was all day long. It was more if I was active. It was a little less if I was sitting down, and luckily not when I was sleeping. But other than that, every waking minute, it was either medium or full on. So, you can imagine why I'm sitting here so high. I'm high is what I am. I'm high on it.
Great. Good success story. Good success story.
Thank you.
Okay,
Jimmy,
Carl.
I don't know
Carl, I haven't forgotten you. Go ahead.
Okay. I'm talking to you remotely for the first time, I think, since I started these meetings. And I'm talking to you from my phone, so hopefully everyone can hear me and see me. Just as a follow-up to last week's discussion with me and the trial that I've been on, the ARV-110 trial. Tall Alan, who most of you will probably know is Alan Adele, who I think is a board member of ANCAN. I had emailed back and forth with him concerning my situation, where my PSA from day one of the trial was 4.3. At the end of week 4, it was 5.6 or 5.8. So I was getting kind of bummed out. And the next step would be in another 4 weeks, I will have scans and to see what things really look like. So Alan had responded back to me. He first asked me, what's your alkaline phosphatase? And I told him 36, and he said, okay, that's a pretty good number. And he said, even your PSA at 5.8 is still relatively low. And that he said that the treatment may indeed be working, because as cancer cells, your prostate cancer cells die, they can give off readings of PSA. So I wanted to pose that out there.
I think he's right.
Ah. Okay.
So I think it's too early to tell, Carl.
Okay. All right. I don't want to take up too much time, so.
Yeah, you know, the problem is the numbers are small, Carl.
Yes.
And normally when we see this happening, it's oftentimes with guys with numbers more like Jake's numbers, where they'll do a chemotherapy, and then we'll see an increase in the alk phos, and we'll see the PSA go up a little bit, and then it starts to go down. You know, with you, we're looking, it's a slow and gradual creeping up. And I don't know how much weight I would put on it's killing off the cells, and that's where the PSA is coming from. But personally, I mean, that's, well, did you say you're out? Did you say something about your alk phos? I was just.
Yes, it's 36.
I mean, that is low, Carl.
That's very low. So that would not, I mean, well, alk phos is really more about bone mets, but
right.
that wouldn't indicate. Normally, we'd expect the alk phos to be high if this was a flare coming from cells dying. So, you know, I frankly, I don't think Alan has a good grasp of your type of cancer, where you don't produce a lot of PSA. And normally we'd be seeing this in people that are PSA producers. And you know, and yes, it's fine in theory, but I don't think it applies to your cancer, which is BRCA driven, and you don't produce a lot of PSA. That's, if you're asking me, that's my thought. What are your plans in terms of continuing on this trial or not?
Actually, I sent an email request to Tagawa last week and requested that the scheduled scans, which will be going to be in 4 weeks, that they be moved up in 2 weeks, which would be this April 19th. I got no response, and I'm not surprised, because he had told me in no uncertain terms, as I mentioned last time, he said, stop focusing on PSA. So I will wait until the scans. I assume the protocol would probably not even allow him to move up the scans other than what the protocol requires, being in 4 weeks from now. So at that point, then it will be more definitive as to where I go from there. And my regular oncologist at Rutgers has said the same thing. Wait until the scans.
Okay, good. Well, keep us updated.
Okay.
Peter, I just want to ask Carl 2 quick questions. Carl, are you still taking any form of ADT or hormone therapy?
Yes, and my last Eligard shot was a 6-month shot, and it's about to expire, so to speak. I know it lasts more than 6 months, but in a few days I will be having my next shot. It'll be a 3-month shot, and I will be having the Xgeva shot as well.
So that's part of the protocol. They want you to continue on ADT, I guess.
Right, correct.
And
yes.
Any side effects at all from this new therapy?
You know, initially there was more fatigue, but they had told me, and it's 3 pills. If I take the 3 pills, not together, but space them out over 10, 15 minutes, that it should reduce the fatigue, and it has. So other than that, I can't say I have any other real side effects.
Okay, good.
Okay, thank you.
Okay, still got several more guys. Scott Schreffler. It's good to have you on board.
Good evening.
Hey, Schreff.
How are you, Rick?
I'm good. How are you? Tell us what's going on in your world.
Pretty much same, just holding pattern. Doing good.
Okay, give
Pray
the
for
guy,
you, Jake.
and give the guys a very quick update on your situation and where you are now, so they know, because you got to have a long memory to remember Shref, right, Jake?
Yeah, I can try. Diagnosed November 17 with metastatic, oligometastatic prostate cancer, and started on ADT. My first shot was December of 2017. Stayed on Lupron and Zytiga through 2019. And at the beginning of 2019, received radiation therapy. I can't think of the acronym. 65 guys, I think it was.
Great.
And I've been off of Lupron and Zytiga since September of 2019, I believe. September was my last shot, and then I went off of it at the end of the year. So I've been without ADT since the beginning of 2020. And my testosterone, I'm due for shots the end of this month, or due for tests the end of this month. And my last testosterone was 72, and my PSA is still undetectable.
Very good.
Hold on, your last testosterone was how much?
Less than 0.01, I think.
No, your testosterone, because I know you.
72.
72.
Yeah.
So your testosterone has never really come back.
No, not yet.
And you've been off for a year and a bit, right?
Yes.
Okay. Okay, so I mean that's.
I did have since that time I've had 3 back surgeries. My back gave out. I think it had something to do with the Lupron, because it just, the first shot went okay, and then from that point on, the 3-month shot was like a torture chamber for me. But it took the testosterone down.
Yeah. Okay, well, I mean, first of all, it's great that your PSA is where it is, because at least we certainly don't have to worry about treatment there, but you know, we'd love to see your testosterone bounce back a little quicker. At the same time, we've known guys, and there may even be guys on this call who did a year or 2 of ADT like you did, and it's taken them a long time for their testosterone to return. Anybody else on the call have any thoughts on testosterone returning? Anybody want to say anything on?
Not yet.
Not yet.
Not yet is what I have to say to that. And it's last September since my last 3-month shot. I'm sitting at about 22. So I don't have raging hormones at this point.
Yeah. And I'm anxious to see more guys get on Relugolix and see what they're up, and do intermittent with that and see how fast they come back, because I hear you come back a lot faster.
My testosterone took a long time to come back, and it still is below the normal 230 mark. It took, gosh, it must have taken close to a year, and I'm still around 213 as of just last week. So it's never really fully recovered, but at least it's close anyway.
Paul, how long did it take before you really saw any sort of recovery at all?
Well, when I went off the Lupron, it came back like about 30 points every 2 or 3 months.
Okay.
So it took a long time, you know, took like at least 8 months, 9 months, maybe 10 months to get up to around 200. And it's never been, I don't think it's ever been up to 230.
Paul, what was your baseline testosterone before treatment? Do you know?
I don't know that, unfortunately.
So many guys don't know that, but I know what mine was, but you know, that may fuel false hope. I don't know. It was really high, but it's not coming back yet.
How are you feeling, Paul, with 213? I mean, you have your energy back, and
yeah, I've got plenty of energy, but you know, yeah, I got plenty of energy. No problem with that.
I got plenty.
My testosterone. Sorry, this is Bob Bordiga. I was just going to say, after my surgery and after the Lupron wore off, mine came back pretty quick. It went up to 700 in 3 months.
Wow.
Yeah, but Bob, you weren't on it for that. How long were you on ADT for?
I was just on it since I think the summer of 19, and then I had my surgery in like beginning of November, and then by the following year in March it was up to 700.
Yeah, how many months? How many months were you on the ADT?
It was a 3 month. The first one was a 3 month, and it lasted longer than that.
Right. So that's one of the reasons why you came back so quickly, because you were only on for a relatively short period of time.
Yeah, I was on for 3 years.
Right. So the longer you're on for, the more and the longer it takes to return. Shref, how are you feeling in yourself, and how are you feeling mentally?
Oh, my brain doesn't work too well. I'm still trying to recover from the multiple back surgeries.
Right.
But I guess you win some and you lose some.
Yeah. Well, you know, we can also hope that you're going to continue to recover. I mean, that's what we hope, and that you'll get more testosterone back. Your PSA will stay low, and your back surgeries will improve your quality of life.
Yeah, I think so. Just a matter of time.
yeah, we hope so. How old are you, Scott? How old are you?
68.
68. Okay.
Yeah.
Well, you got years ahead of you. You know, we hope the back stuff heals for sure.
And show up every so often, because we like to say hello to you, Scott.
Oh, I really appreciate. I've been watching YouTube, watching the meetings on YouTube. It's helps when I can pause everything.
Yeah, come along to this. Okay, time for a commercial. Is Rich Jackson still with us?
Yes.
Mr. Jackson, time for a commercial for Thursday.
It must be off. We have 2 more people. Keep going, Rick. Let me get.
Let's do the commercial right now before we lose them. Thursday.
Yeah, I don't see Rich Jackson's mic on.
Okay. Are you there? Are you there, Rich?
No.
Okay. So Thursday is our Speaking Freely call, which is moderated by Rich along with John Ivory and Russ, and I hang in a little bit there. And it's to talk about everything other than treatment. And so it's a great place to be talking about mental health and how you deal with cancer in the workplace, with your family, any other issues that really you want to bring up, like Rich Jackson's calendar that's behind his left shoulder. You can talk about whatever you want, and we'd love to see you there. It's at 8 o'clock Eastern on Thursday in this room. So please stop by. It's a fun group.
Okay, Paul Frieda, do you have something else you want to talk about? You mentioned you wanted some time.
No, it's just real quick, just to, I got my latest blood test showed PSA less than 0.1 again, so that's all.
Very good.
Good news,
Okay.
yeah, good news.
Okay.
Congratulations.
Thank you.
Len.
Am I the last one, Peter?
I think so, unless I'm missing somebody.
Anybody else?
I can
Dennis,
give a
go
quick.
to Dennis.
Oh,
I got to give a quick update once you're done, Len.
okay, then go ahead,
Yeah.
Herb.
No,
Len
let's go to Dennis first and then Herb.
Okay, Dennis.
Go ahead, Dennis.
Okay, I got some blood work back today, and intermittent therapy, and my PSA is taking a big jump. Not total number wise, but if you looked at the doubling time, it's 0.8 months, less than a month. It went from a 0.1 to 0.9. So I mean, it looks low from a number standpoint, but when you run the doubling time numbers on it, the velocity comes out like 0.3 nanograms per milliliter per month, which looks to be pretty aggressive to me. And I have an appointment scheduled tomorrow with my local oncologist, and I was putting together questions for him, and I thought I'd run some of these by you folks here that have been doing the intermittent therapy. When do you restart? I'd be surprised.
How many months was it doubling? How many
Pardon?
months was it doubling?
0.8. 0.8, less than 1 month.
Less than 1 month. Okay.
Yeah, but Peter, it's at very low levels. It went from 0.1 to 0.9. Even so.
Yeah.
Right.
Go ahead, Dennis.
So I'm just wondering about, what point will I need to restart? What therapy will I go on? And should I go to monthly? I've been checked every 3 months. I think now it's time to maybe change it to every month. And will I need to do any scanning?
Have you done a PSMA scan?
No.
I'd ask before you start going on any drugs again, I'd ask if you can get in. If you're at 0.9,
This PSA is low. The scan won't show anything.
Huh?
Did you have those?
Yeah, I never had a prostatectomy.
Hold on a second.
That-
PSMA scan will show something at 0.9. If that's where you are, if you're at 0.9, a PSMA scan will show something, and you could if your doc can get you in it in LA, that might be an option.
Yeah, I just there's 2 points where they look at it. If you've had a prostatectomy, then it's equal to or greater than 0.2, you could get a PSMA. Or if you had a 2 milligram rise from your nadir post radiation, then you can do a PSMA. But I still have my prostate, so I don't really know what the PSA, I guess, eligibility for getting it at that situation.
Was it the same lab that did both tests?
Yes, yeah, both labs are the same.
Okay, so
It just seems to me you should do like with this doubling, you should just have a retest before you take another step.
yeah, I mean, I think that's a good point, but I want to make a couple of points here to take this into consideration. Okay, so Dennis still has his prostate, and he's coming off of hormone therapy. Has your testosterone registered yet, Dennis?
66.
And what was it last time?
9.
Okay. So what we're seeing here, and we got to take this into account, is now your testosterone is starting to come back and you have a prostate. So the prostate cells are starting to get activated. Doesn't necessarily mean that the PSA is coming from distant cells, could be from the prostate. So what we've got an issue here, you've never had the prostate treated, correct, Dennis?
That's correct. No, I never
Right.
had it.
So, you know, before we start getting hyped up about, oh, it's gone from 0.1 to 9 and look what's the doubling time and everything else, hey, you're not on hormone therapy. This is what happens when you're not on hormone therapy. We really need to see where are you going to go and to what level, because you could get up to something like 4, a level of somewhere around 4, and that might be perfectly normal because you still got a prostate. So I think, and you know, we immediately think, oh, prostate's going up. Wow, this is a big deal. He's got to have prostate cancer. We're not sure. So when you meet with a medical oncologist, you're going to have to say to him, look, how do we discern between natural PSA versus PSA that's coming from distant spots? And I think the way to go is exactly what Peter said, that we need to get some scanning done. And if that means that you've got to see a couple more rises, okay, so you'll see a couple more rises. You could do an Axumin test right now. It might not be fine enough. When was the last time you had a scan, Dennis?
Last August, it was just a regular bone scan.
And what did it show?
No activity.
Okay. So, you know, we're not going to see, we shouldn't expect to see anything on a regular bone scan. You're probably going to need to have a defined scan, an Axumin or a PSMA scan. And I think the planning now is where to go with that, and you know, definitely to touch base with Dr. Singh,
right,
and to get a plan in mind. You know, the problem is if you talk to Peter, you talk to Len, you talk to some of the other guys who have done intermittent, when they came back, when their PSA started to come back, they didn't have a prostate.
Right.
And that makes you very different to comparing to them.
Right. No, I know that. That's why I mentioned that, to remind everybody that I still have a prostate. It's I'm not intermittent.
You never had radiation,
Len has a prostate.
Dennis?
What's that, Peter?
Len has a prostate still.
Well,
Len had it treated. It was treated.
I had radiation. You had no radiation, Dennis?
That's correct.
Yeah, there's a difference there.
You see, yeah, I mean, you can have a prostate, but if it's been, I got a prostate, but it was blasted with all kinds of radiation. So, okay. But when you've got a healthy prostate, which Dennis has, then it's we got a whole different ball game to think about this, and that's what I want to remind you. Ravi, I just see you just came on. This meeting starts on a Tuesday at 2 hours earlier. It starts at 6, not 8. We're about to finish.
Yeah, I think I don't know what went wrong here. Anyway, thank you.
Okay, just wanted to let you know, but it is recorded. It will be on the YouTube channel and on our blog. So that, you know, I just wanted to to mention that. Anybody else want to say anything about Dennis's situation?
Yeah, Dennis, I think it takes at least a couple of months at UCLA if you get on the list to get a PSMA scan. So I would talk to Dr. Singh and see if he can pull some strings and at least get you on the list. I wouldn't worry too much about whether you qualify or not or anything like that. You could probably get in. Are you a military vet at all?
No, I'm not.
Okay.
Okay. I mean, I think that's the drill down there with your docs, Dennis, to say, I mean, to me, do you have any idea how large your prostate is?
No, it was not particularly enlarged when I started.
Okay. And it's probably shrunk because of all those years of hormone therapy anyway. So, you know, I think you have to say, look, we'll let it run till it gets to some number. You know, whether that number is 2 or 10, you've got to come up with what you feel comfortable with, and then we're going to scan.
I think I got to change the frequency from getting a blood work every 3 months to every month, because at the rate it's moving pretty quick right now. So.
But again, remember that might be a function of your testosterone coming back and not cancer growing.
So test the testosterone at the same time as you do the PSA and keep track that way.
Yeah.
That's what I do.
Yeah.
That's what I've been doing. Yeah, I remember now for about 4 years I was at less than 0.1 on testosterone and on the less than 1 on testosterone, less than 0.1 on PSA. After my chemo and Lupron and Zytiga.
Right.
Well, there's no reason why you couldn't go to monthly testing. I've been doing monthly testing for about 6 years, and it's a no-brainer for me. I just do it.
Yeah. And here's another question to ask your doc is, what impact would the chemo have on the actual prostate? Because the chemo works on the cancer wherever it is. It doesn't know whether it's distant or in place. So it could be that chemotherapy treatment may have some impact on how the prostate functions and how it produces PSA. That's a pretty technical question, but the doc should be able to respond to that.
Yeah, you know, I had a fairly good reduction with the initial chemo, but then it came back in less than a year. And that's when I went on the Zytiga, and it really knocked it down quickly. And I know that's, you know, that's that goes after the other androgen stuff. So, but I think you're right. The scan is something we should be looking at.
Yeah, well,
frequent
talk carefully with Dr. Singh, because if he wants to put you back on Zytiga or back on hormone treatment to knock it down, talk about scans, because you're in a sweet spot now for a scan, and you could just be putting it off if you went back on Zytiga.
Yeah, where did you say the PSMA scans are?
It's approved at UCLA.
Yeah. UCLA, that's what I thought. Yeah.
Yeah, I mean, I don't think with a healthy prostate, I don't think they're going to rush him back onto hormone therapy as quickly.
Hope so.
It's a different situation to you or Len or somebody else.
Yeah, but Rick, the one caveat here is, if I remember correctly, Dennis, that I think at diagnosis had some bone mets, or no?
Yeah, large volume, 7.
Yeah, so it's possible there's some activity there. It might not be the prostate.
Yeah, but Len, there was nothing in August. We looked in August. When did you say?
Yeah, well, it's actually probably the month before, June or July, and I went off all the treatment. We're not intermittent in August.
Okay.
But I had get about, I think about a month or so before when my last.
Len, you
Yeah,
could.
that was just a regular bone scan, no, Rick. It wasn't Oxman.
But you know, I'm not arguing, Len. I hear you. All I'm saying is it's all a different level of measurement. We don't usually talk to men who have a healthy prostate. We've got to touch base with Bob Bordiga, and we've got to get out of this room within about 2 or 3 minutes.
Okay.
5 minutes. So
thanks.
Bob, is everything okay by you?
Yeah, I think it's pretty good. Here, I could be quick about it. I've been on Lupron, a 6-month shot now, that I took last August, and my PSA because my PSA went back to normal, and because it started to rise a little bit. I mean, my PSA was negligible, but it started to rise when I did the ultra sensitive. It went from 006 to 016 to 080, and then to 0.1, and then I went on the 6 month. So I've been on the 6 month for about 8 months now, and my testosterone's starting to rise. And my urologist says he wants to wait a little while to see what happens, and if it doesn't go above 0.1 or 0.2 is what he's looking at. His number is 0.2. If it doesn't go above 0.2 to stay off of the Lupron. My thinking is to go back onto the Lupron just to make sure that the cancer doesn't have a chance. And as far as I'm concerned, if I had to stay on Lupron for the rest of my life and it was something that would be preventing the cancer from coming back, it would be worthwhile. So I just wanted your thoughts about that.
Okay, so I just need to go back with you. You had the surgery, right? You did
right.
you did your surgery, and then you went on to LHRH and you did radiation.
No radiation.
No radiation. And how long were you? Why did remind us? Why did you go on to the Lupron?
Because I did the ultra sensitive PSAs, and then as the Lupron was at 3 months after surgery, and it started to go up at a faster rate, but it was still very low, and because it was doubling quickly, I decided to go on to the Lupron right away, and I went on to it. And
when was that?
That was in March, was the first shot, and then I got another one, the 3 month shot, and then I got another one in August.
Okay, March of what? March of 20?
20, yeah, right.
Okay, so I'm just so in March of 20 you started the Lupron.
Right.
And you've been on that continuously ever since, right?
That's right.
And you are when did you get your last shot?
8 months ago. A 6 month shot 8 months ago, so my T level's starting to come up again. It's okay. 46 now.
Okay.
But I expect it to rise fairly quickly, and I just don't want to give it a chance.
What was your post? What was the
post?
It
went up to 700 is when it went up to.
Right. What was your Gleason post-surgical Gleason?
9. 4 plus 5.
4 plus 5.
And they did find a little bit when they did after the prostate was removed. They find a little bit in one of the lymph nodes that they dissected.
Okay. So I think those are the facts for the guys to consider. And the question is, how long would you stay on the LHRH?
Was there any consideration of a PSMA scan to find out where the activity was?
I did have an aximum scan that was negative.
Okay.
And when was that? what level was the PSA when you had the Axumin scan?
I don't know. I have to look it up to see, but it was before my surgery, I think.
Yeah,
but
well,
they started as soon as I had my biopsy. They started me on the Casodex and then Lupron.
Right. So I see it was back around 719. You had that Axumin before surgery. So that really isn't
I
what
think so.
we're driving at. I mean, what we're driving at right now is your PSA is what level right now?
Less than 0.1.
Less than 0.1, and your doc has kept you on for about 6 months, and you're wondering, should I do more than 6 months?
Oh, I want to keep going. Yeah,
As
I think I want to keep going.
And I can't remember. Are you at Kaiser?
Yes, in Los Angeles.
Right. So, this is the problem with Kaiser. I think that if it were me and I was 4+5, and there was suspicion, I'd do one of two things. Either I'd stay on the Lupron for 18 months. I think that's reasonable. Or I'd come off the Lupron, let my PSA rise, and get an Axumin or a PSMA scan. So if you don't continue, then it's got to be with the understanding that when your PSA hits a certain point, you're going to get another Axumin scan.
Yeah, 0.2, I think, is what he told me.
I mean,
We didn't talk about a scan, but he said that was the level that.
Well,
right.
I mean, that's the level where they want to jump in and do radiation, but you want to know where it's coming from.
Right.
Right.
Yeah.
I mean, what he's saying is he's giving you the old, the 0.2 is the level, and then we'll jump in and then we'll do radiation because you're post-surgery, but you were 4+5. You knew you were 4+5. You wanted to do it. And they decided not to radiate at the time. There may be a node involvement. I think there was a node involvement on the surgery.
Right. But a small section of one node. That's all.
Yeah, but that's enough. So
yeah, I know.
I think either I don't know. Thoughts, anybody?
Yeah, the old way of thinking was that when you get to 0.2, then you radiate the prostate bed and the pelvic girdle, and just kind of shoot for just do a crapshoot there and see if you can get it, because that's where the thinking was. But now the PSMA scans change the whole equation, and you have the ability now to kind of see a little more detail of where the action is. But if you stay on Lupron, you're just going to put off that, which is okay. Eventually, you might become resistant to it, but it's whatever I mean, you seem to feel very strongly you want to stay on the Lupron, and I get it, but
well, that's my thinking, but it's just I don't. I'm sorry. I just thought that if I keep the testosterone down through the Lupron, the testosterone is what activates the cancer cells, and so that seems to me to be, at least something that makes sense to me. That as long as I'm able to tolerate the Lupron, which I am, so far has not been an issue with me, that I would just stay on it.
I don't think it's a bad plan. I think what's really required in your case at some point is a scan. If your PSA is starting to rise a little bit, I might say, okay, let's just let it rise and find out where the cancer is. Unfortunately, we've got to shut the room down because I've got I've got multiple sclerosis people trying to get into the room now because their meeting starts in 7 minutes. But I'm sorry to shortchange you, Bob. You feel free to give me a call or to give Peter a call.
Okay. All right. Thank you. Thanks, everybody.
Okay, guys. Thanks very much. I think we covered a lot of ground tonight.
Bye.